I'm Dr. Michael McInnes. I'm an internist, and today I'll be talking about anti-diabetes drugs other than insulin. Most of these drugs are used for type 2 diabetes. We covered the basics of diabetes and the use of insulin in a separate lecture, so today we'll just jump right into the oral agents and other drugs used for diabetes. I'm going to skip around a little bit today and not follow the order of Lippincott's pharmacology book. We're going to cover the most important drugs first. We'll cover the most commonly used drugs, the ones you have to know, which include the sulfonylureas, metformin, and the thiazolidine diones. We're also going to cover some of the newer drugs, the DPP-4 inhibitors and the incretin mimetics. And then last we'll talk about some of the uncommonly used drugs, which is the amylin analog pramlintide and the meglitinides and the alpha-glucosidase inhibitors. So beginning on page 291, we'll start with the sulfonylureas, which are insulin secretagogues. That means they increase insulin secretion. We primarily use these early in type 2 diabetes. Now, why are these only used early in type 2 diabetes? Well, these drugs require a functioning pancreas to work. And patients with type 1 diabetes don't have a functioning beta cells, and very often late in type 2 diabetes, patients' pancreases have lost the ability to produce insulin at all or have very weak insulin production. So early in type 2 diabetes, their pancreas is still producing insulin. In fact, they're producing a lot of insulin, and these drugs, the sulfonylureas, are going to help the pancreas make more insulin and secrete more insulin. The drugs we're talking about include tolbutamide, which is a very old drug. It came out in the 1950s. It's not very commonly used anymore. We also have a second generation sulfonylurea called glyburide, which is very commonly used, glipizide, and then glimepiride, which is considered a third generation. And all three of these that begin with G, glyburide, glipizide, and glimepiride, are all very commonly used. The mechanism of action for sulfonylureas relates to how the beta cells secrete insulin. I showed this slide in the lecture on insulin. This is our diagram of the beta cell. The normal mechanism that allows for secretion of insulin is that the glucose transporter allows glucose to enter the cell, and that glucose is metabolized, so you get a rise in ATP, and the ATP causes this potassium channel to close so that the cell membrane depolarizes, which opens this voltage-gated calcium channel, allowing calcium to flow into the cell, and insulin is secreted. So sulfonylureas act on this mechanism. They bind to and close this potassium channel, which causes the cell membrane to depolarize, the calcium channels open, and insulin is secreted. So to summarize, the mechanism of action of sulfonylureas is to increase insulin secretion. Pharmacokinetics. These are oral drugs. They're metabolized by the liver and then excreted by the liver and the kidney. So you have to be careful in patients who have renal insufficiency. Renal insufficiency will cause these drugs to stick around longer in the system and prolong their insulin secretagogue effect. The first generation drug, that tolbutamide, which I said is not very often used, has a very short half-life, only 4 to 5 hours. So it makes it a little safer for elderly patients if you're concerned about hypoglycemia. But again, this drug is not widely used. The second generation and third generation drugs, glyburide, glipizide, glimepiride, have a much longer half-life of about 24 hours. So these drugs will stay in the system a lot longer, and they can be dosed once a day. Adverse effects of sulfonylureas. The primary adverse effect you need to be aware of is hypoglycemia, especially in the presence of renal insufficiency, as I mentioned. If you look in Lippincott on figure 2412, it shows a large number of drug interactions. Just to go over some of the common ones, sulfonamides, salicylates, allopurinol, all these through various different interactions will cause an increased risk of hypoglycemia because they make the sulfonylurea more potent. Moving on to page 292, we'll talk about the insulin sensitizers. Instead of increasing insulin secretion like the sulfonylureas, these drugs make insulin more potent. They increase the function of the native insulin. Remember, insulin resistance is an important part of type 2 diabetes. So if we can make that insulin more functional, make the body more receptive to insulin, make the body more sensitive to insulin, then the blood sugar is going to be lower. There are basically two types of insulin sensitizers that we'll talk about: biguanides and thiazolidine diones, or TZDs. So first we'll talk about the biguanides. And really there's only one of these that we use for diabetes, and that's metformin. This is considered a first-line drug for type 2 diabetes. The American Diabetic Association recommends this for all patients when they're first diagnosed with type 2 diabetes. It's often used in combination with insulin and sulfonylureas and TZDs. The mechanism of action of metformin, it inhibits hepatic gluconeogenesis. It also improves peripheral tissue glucose uptake, and it has some effect on the lipids. It modestly lowers LDL and it raises HDL a little bit, so it has some additional benefits. Pharmacokinetics, again, this is an oral drug. It is not metabolized. It is excreted completely unchanged into the urine. So think about it. When would that be dangerous? Well, if a patient has renal insufficiency, or if they are undergoing a procedure that's going to reduce their renal function, that metformin is going to stick around longer in the blood and have more potential for adverse effects. So what kind of adverse effects are we talking about? Generally, metformin does not cause hypoglycemia. It does not cause weight gain, unlike insulin. But it does have some nasty GI effects. It can cause nausea, diarrhea. These are pretty common, but they're not very dangerous. A more dangerous, but thankfully rare complication or adverse effect of metformin is lactic acidosis, which is especially a problem if a patient has renal insufficiency. So any patient on metformin, you need to monitor their creatinine. If their creatinine rises above 1.5, you need to take them off the metformin, whether it be temporarily or permanently. If you have a patient who's having a procedure that involves IV contrast, such as an angiography or a contrasted X-ray or CT, they need to come off the metformin for 48 hours after they've had that contrast load, because that contrast can be toxic to the kidneys, and therefore they could get some renal insufficiency transiently, which could increase their risk of lactic acidosis. So you stop the metformin, it's not a problem. Metformin can also impair B12 absorption, so that's something to be aware of. Let's talk briefly about some other uses for metformin. It's sometimes used for the treatment of polycystic ovarian syndrome, or PCOS. This is another disorder that's associated with insulin resistance. Women with PCOS often are infertile, and if you treat with metformin, you can have a 4-fold increase in fertility. There's another biguanide just to have heard of called proguanil, which is used for prophylaxis for malaria. It's not used for diabetes, but it is another biguanide just to mention. Moving on then to another insulin sensitizer, the thiazolidine diones, or TZDs. Sometimes these are called the glitazones because all the drug names end with that suffix, glitazone. The drugs we're talking about, there's troglitazone, which was the first one in the class, was a very popular drug. Unfortunately, it was taken off the market because of liver toxicity. The two that are still on the market are pioglitazone and rosiglitazone. These are used, again, in type 2 diabetes, usually as a combination with insulin or with metformin, but they can be used in monotherapy. They can be used in combination with sulfonylureas. Mechanism of action of these drugs is not really well understood. Both of these drugs work a little bit differently, but there are a few general concepts to understand. They're both ligands of the PPAR gamma receptor. That stands for peroxisome proliferator activated receptor. They both regulate adipocyte fatty acid production and secretion, and they also regulate glucose uptake and utilization. And, this is the important one, they increase insulin sensitivity in muscle tissue, liver tissue, and adipocytes. The pharmacokinetics of the TZDs, they are oral drugs. They are extensively metabolized by the cytochrome P450 system. Pioglitazone is hepatically excreted. Rosiglitazone is renally excreted. But the nice thing about these, you do not have to adjust the dose with renal insufficiency. Unlike the sulfonylureas and unlike the metformin, you don't really have to worry too much about it. As far as adverse effects, a couple of important things to know about. First of all, you should monitor liver enzymes, at least at first. The risk of hepatotoxicity is pretty low with the two drugs that are still on the market, but with all the stuff about troglitazone being taken off the market for hepatotoxicity, it's still a good idea to at least be aware of what the patient's liver function is doing just before and just after you start the drug. These drugs can cause weight gain, and they can cause a lot of fluid retention and edema. So this is a big problem in patients who have congestive heart failure. If you start to have a lot of fluid retention, you could put the patient into pulmonary edema. It could be life-threatening. They could exacerbate their CHF. They could wind up in the hospital. So these drugs have a black box warning on their prescribing information by the FDA. That's the strongest warning the FDA can put on a drug without taking it off the market. This is black box warning that says you shouldn't use them with CHF, or you should use them with extreme caution. In late 2010, the FDA put rosiglitazone on a restricted access program so that it's only available to patients who are already taking rosiglitazone or patients who are not taking it but are unable to achieve glycemic control on other medications. And you have to document that you've discussed the risk of MI with these patients, and you have to enroll in the special program. So you can still prescribe it, but it's much more difficult than it used to be. Pioglitazone seems to be okay. There's no evidence of increased risk of MI with pioglitazone. There are a couple of other potential uses for TZDs. One is, again, experimental use for treating polycystic ovarian syndrome. And then sometimes these drugs are used off-label to treat fatty liver disease or non-alcoholic steatohepatitis. This is a condition where you have a lot of fat building up in the liver. It can be toxic to the liver. It can be a precursor to cirrhosis. So it's a pretty common condition, a pretty serious condition. Because the TZDs are involved in adipocyte function and regulating secretion and synthesis and storage of triglycerides, obviously giving a drug that's going to affect that can be pretty useful in treating this condition. But that's not an approved use, that's an off-label use of the drugs. So those are the most common oral drugs for diabetes: the sulfonylureas, metformin, and the TZDs. You definitely need to know about these.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
Okay, one more time. Which oral diabetes drug can rarely cause lactic acidosis? Metformin! Pay attention! Metformin! Now, which class of diabetes drugs can cause fluid retention and CHF? TZDs, like pioglitazone and rosiglitazone. You had better wake up and learn this stuff before you kill somebody!
Hi, I'm Dr. Chris Lewis. I'm here for your quick review number 1 on your lecture about other diabetic medications. Let's get started. Which anti-diabetic category matches the following side effect? Hypoglycemia. That's going to go along with sulfonylureas. May cause lactic acidosis. That's going to go along with metformin. Contraindicated in moderate to severe CHF. Think of TZDs and metformin. Slightly increased risk of MI or myocardial infarction. That's your TZDs, more specifically rosiglitazone. Mechanism of action stimulates insulin release from beta cells. That's going to be sulfonylureas. And then another mechanism binds the PPAR gamma and increase insulin sensitivity. That's going to be your TZDs. Next, a 60-year-old patient with diabetes mellitus for 10 years is currently taking metformin, glyburide, and pioglitazone. His hemoglobin A1C is 8.5, and he has subsequently started on insulin therapy. What alteration in his oral diabetic medication should be made? We have to start him on insulin because nothing else is working at this point. So when you start someone on insulin, potentially you're going to run into hypoglycemia. So you're going to want to think about, first, starting the insulin very slowly, and 2, you might have to decrease some of those oral meds. Now, one med you might want to think about stopping is the glyburide. Glyburide actually needs beta cells to be secreting insulin for it to be effective. And since we're adding in insulin therapy anyway, it's a bit of a redundant action to try to squeeze more insulin out of the pancreas and add exogenous insulin at the same time. So that glyburide may not be doing anything at all. Next, a 35-year-old diabetic female that smokes and is on oral contraceptive pills comes to the ER for acute chest pain with shortness of breath. Physical exam reveals an edematous right ankle, tachypnea, and tachycardia. It is decided that she needs imaging to rule out pulmonary embolism. In this patient, why might a VQ scan be preferred over a CT scan of the chest? Well, you want to think about contrast-induced renal failure in diabetics. So someone's on medications that could potentially make it complicated to use IV contrast. And then 2, you also have to worry about your diabetic patients who are taking metformin. You know, metformin is a contraindication for CT scans with contrast, so be on the lookout for those 2 things. What are the contraindications to metformin? Well, first, renal disease. So if anytime you have a creatinine over 1.5, you want to either take someone off of metformin or not start it in the first place. 48 hours after IV contrast, you don't want to be using much metformin either. But you want to be cautious in any other renal disease, any hepatic disease, acute MI, or any severe infection. And also in DKA, you want to avoid any potential for lactic acidosis. Next, a patient taking glipizide comes to the clinic for hypoglycemia. What is the most appropriate course of action in this patient? Well, first you're going to want to test the glucose. You know, some people who think they're having some hypoglycemia actually aren't. So first thing, know what you're trying to treat in the first place. So if low, you need to give this patient some glucose. So some people will carry around glucose tabs. If it's in your office, you should probably have some of these around as well. If not, you can certainly use other things like fruit juices or soft drinks, something that has a sweetness to it. You don't want to use complex carbohydrates. You don't want to give someone some rice when they're having a hypoglycemic episode. Now, if they're having some severe hypoglycemia, you might want to think about admitting these patients for 24 hours into the hospital. A lot of these medications have long half-lives, and even though you treat that hypoglycemia in the short term, they might get hypoglycemic again. So consider a brief hospital stay for some more worrisome hypoglycemia. And then you're probably going to want to stop your glipizide if this is a recurring problem. Now, if it was just because they weren't eating appropriately, then you could probably continue the glipizide. But if it's a recurring problem, then glipizide, that is one of the major side effects of that medication, which is hypoglycemia. So think about stopping that altogether. Next, what medication cocktail is commonly seen in older patients with a long history of type 2 diabetes? Well, this is maybe a little misleading. This isn't just anti-diabetic medications, but you do want to have diabetic meds. You want to have all of your diabetics that are older on aspirin, because what's the most common cause of death in diabetics? Well, it's coronary heart disease, so you want to have their aspirin on board. ACE inhibitors are very important for two reasons. One, it helps get their blood pressure into the ideal range, so you want to get that below 130 over 80. But it also has some renal protective qualities as well, so it'll help protect your kidneys long term in diabetics. And then finally, most often you'll see someone on a statin, so you have to have lower than average LDL in your diabetic patients. You want your LDL below 100, so often you'll have patients on statin drugs to lower that LDL. Next, what is the goal hemoglobin A1C in patients with diabetes mellitus? You should know this one already, that's 7. Next, how much should you expect an optimized oral diabetic medication to reduce hemoglobin A1C after several months of use? This is a real general question. You want to think probably around 1%, maybe 2% if someone's really sensitive to a medication, but you're not going to get more than about 1%. So this is important because if you have a new onset diabetic and their hemoglobin A1C is 13, you're probably not going to get away with using one drug and getting them under control. So think of 1 to 2% for each drug. And that's going to conclude our quick review number 1.
So that's it for this quick review. Let's get back to your main lecturer.
Next, we're going to discuss some of the newer drugs. These haven't really completely caught on yet, but they're interesting, they're novel in the way they treat diabetes, and it's pretty testable stuff. They may become widely used, they may become very popular in the near future. So looking at page 295, we have the DPP-4 inhibitors. That's dipeptidyl peptidase 4. The drugs we're talking about are sitagliptin and saxagliptin. Saxagliptin was just approved in 2009. It's not even in your Lippincott text. Before we can really talk about the mechanism of action of these drugs, let's talk about incretin hormones. Incretins are hormones that stimulate insulin secretion and inhibit glucagon secretion. So if you have more insulin and less glucagon, you're going to lower blood sugar. The incretin hormones include GLP-1, which is glucagon-like peptide 1, and GIP, which is gastric inhibitory peptide. It's also called glucose-dependent insulinotropic polypeptide. Whatever you call these things, DPP-4 is the enzyme that inactivates the incretins. That dipeptidyl peptidase 4 is going to deactivate the incretin hormone. So the way these drugs work, they inhibit DPP-4, so the incretins stay active longer. You have more insulin, less glucagon. So think about it. Are these going to be used in type 1 diabetes or type 2 diabetes? These are only for type 2 diabetes. They require a functioning pancreas. So we can use these drugs in monotherapy or in combination with insulin, metformin, TZD, sulfonylureas. You have to be careful if you're using them with the sulfonylureas. Why? Because they might cause hypoglycemia. They're going to increase insulin secretion, just like the sulfonylureas are increasing insulin secretion. If you get too much insulin, you can get some hypoglycemia. These drugs, these DPP-4 inhibitors, are modestly effective. They are not as effective as some of the other drugs that have been around a little bit longer. They're relatively new, and therefore they're still under patent, they're still branded, and therefore they're very expensive. Pharmacokinetics, these are oral drugs. They are excreted unchanged in the urine, so renally excreted. And in the patient with renal insufficiency, you have to reduce the dose. This is becoming a common theme. A lot of these medicines are renally excreted, and a lot of them have to be dosed appropriately for patients with renal insufficiency. As far as adverse effects, we're in pretty good shape here. But these drugs are very well tolerated, not a lot of side effects. You can have some risk of hypoglycemia, as I mentioned, especially if you're using them with sulfonylureas. In general, these drugs have less risk of hypoglycemia if you're using them by themselves or if you're using them with metformin or TZD. Moving on then to page 296, we have the incretin mimetics. The drugs we're talking about include exenatide and a brand new one just approved in 2010, liraglutide. That one's not even in Lippincott. Liraglutide, a new drug. These drugs have a unique mechanism of action in that they mimic the action of the incretin hormones. So we're talking about two different drugs. They work a little bit differently. Exenatide is a synthetic version of a hormone called exendin-4. Now, exendin-4 is found in the Gila monster saliva. Gila monsters are large, poisonous lizards that live in the southwestern United States. And they produce this hormone exendin-4. It's produced in their saliva. It's actually stored and concentrated in their tail for some reason. But the exendin-4 has biological properties very similar to the incretin hormone called GLP-1. Now, liraglutide is a little bit different. It's actually an analog of human GLP-1 that's synthetically created. So both of these are going to mimic the action of GLP-1, which is to increase insulin and decrease glucagon. Pharmacokinetics of these drugs, exenatide has a very short half-life of only 2 to 3 hours. It stays in the body about 10 hours, so it has to be dosed twice a day. In 2010, there was a weekly form of exenatide that was not approved by the FDA. It may still be approved in the future, but as of right now, it is not approved. Exenatide is renally filtered and then degraded. So again, in renal impairment, you have to lower the dose. And in patients with complete renal failure, end-stage renal disease, you cannot use exenatide at all. Liraglutide, on the other hand, has a much longer half-life, 11 to 13 hours. So you can dose it once a day, which is pretty convenient. And you do not have to adjust the dose for patients with renal disease. So these are polypeptide hormones. So are these oral drugs or injection drugs? These are injectable drugs. Remember, polypeptides or proteins are broken down in the gut into their component amino acids. So if you were to take it by mouth, it would be decomposed and degraded before it was absorbed. It would have no action systemically. So these are drugs that have to be injected. They're only approved for type 2 diabetes, usually used as add-on therapy for patients who are already on the oral drugs, and they're not getting full control of their diabetes. Technically, neither of these drugs is approved for use with insulin, although they're often used that way. It's not at all uncommon for an endocrinologist or an internist or a family practitioner to prescribe these drugs to someone who's already on insulin and other therapy because they're already on 3 oral drugs and insulin and they're just not getting their blood sugar under control. You throw anything you can at them, including these new injectable drugs. In terms of adverse effects, there are some things to know about. First of all, there's some GI intolerance. It can cause nausea and vomiting. It can cause diarrhea. It can also cause satiety and anorexia. It's kind of the mechanism of action of how these drugs work, but it can lead to weight loss. Now, interestingly, they use this side effect of weight loss as a selling point. They try to tell people, unlike the TZDs and insulin, which are going to increase your weight, these drugs are going to actually help you lose weight. Unfortunately, it's not a great deal of weight loss. It's about 2.5 kilograms, which is 5 or 6 pounds. But some patients are very willing to do that. Anything they can do to lose a little weight will be helpful. And so sometimes you can sell patients on taking this drug by telling them that it may help them lose a little bit of weight. There's a rare incidence of pancreatitis with these drugs, so you need to be aware of that. And it's important to know that liraglutide has an increased risk of medullary thyroid cancer in rodents, in lab rats and that sort of thing. So patients who have a strong family history of thyroid cancer, if they have the multiple endocrine neoplasia syndrome, and they're at high risk of medullary thyroid cancer, there's a black box warning on liraglutide that they shouldn't take it because of the increased risk of thyroid cancer. So the DPP-4 inhibitors and incretin mimetics are some of the newer anti-diabetic drugs. They have similar mechanisms. They are very different from the way some of the other drugs work. Definitely testable material. And now we're going to cover the last few drugs that just aren't widely used, but at least you've heard of them. So on page 290, we're talking about synthetic amylin analog. There's really only one of these products. It's relatively new. It's called pramlintide. It was released in 2005. So amylin is a hormone that's produced in the beta cells right alongside insulin, and it's released with insulin. So type 1 diabetics, they've lost their beta cells. They're not going to make any insulin. They're not going to make any amylin either. Amylin reduces the body's demand for insulin in two ways. First of all, it delays gastric emptying, and it improves satiety. And then it also decreases glucagon secretion. So the drug we're talking about, pramlintide, is a synthetic analog of amylin. It has the same effect as native amylin. It delays gastric emptying, and it also decreases glucagon secretion. It's given as a subcutaneous injection just before meals. So like insulin, it's a protein. You have to give it as an injection, and you have to give it just before meals. It can be used in type 1 diabetics or type 2 diabetics who are on insulin. When you do give it with insulin, you have to reduce the amount of rapid-acting insulin that they're getting with their meal because you're reducing the amount of insulin they need, and they could get hypoglycemia if you don't adjust their insulin dose. The adverse effects of pramlintide are primarily gastrointestinal. That can cause nausea and vomiting. It can cause anorexia. So you especially want to avoid this in patients with diabetic gastroparesis. This is a condition where you have sort of a neuropathy. You have damage to the nerves that are innervating the stomach, so the stomach does not empty normally. You have delayed gastric emptying. You have early satiety, bloating. Sometimes they can get nausea and vomiting because their stomach's just not emptying the food into the intestine. So if you give pramlintide, which is going to delay gastric emptying, you can make that gastroparesis a lot worse, which is pretty uncomfortable. Next, let's skip down to the bottom of page 291, and we'll look at the meglitinides. Now, I'm not sure why Lippincott called these meglitinide analogs. Meglitinides is the class name for the drugs. The drugs we're talking about are repaglinide, which is an old drug. It's not widely used, and a newer drug called nitaglinide, which is also not widely used. These drugs work by an interesting mechanism. They're also insulin secretagogues, similar to sulfonylureas, but they bind to a different site on that potassium channel that we were looking at earlier. So they increase insulin secretion by the same way, but technically they're not sulfonylureas. This is only used, again, for type 2 diabetes because, like the sulfonylureas, it requires a functioning beta cell. These have a very fast onset and a very short duration of action. So you have to take them right before you eat, and you can take it about 30 minutes before you eat. As far as pharmacokinetics, these are oral drugs. They're metabolized to inactive products by the liver and then excreted in the bile. So you don't have to worry about renal function with this one. In terms of adverse effects, they can cause hypoglycemia, but less so than the sulfonylureas because they work so quickly. They work such a short period of time. You take them just before you're eating. If you take them correctly, you shouldn't get a lot of hypoglycemia. If you take it between meals, not only are they not going to do you any good, but they could cause hypoglycemia. These drugs also have a lot of drug interactions. They're metabolized by cytochrome P450 3A4. So the drugs that inhibit this enzyme will reduce metabolism of the meglitinides and increase their glucose-lowering effects. These drugs include some of the antifungals, ketoconazole, itraconazole, fluconazole, and some of the macrolides, erythromycin and clarithromycin. Drugs that induce this 3A4 enzyme will increase the metabolism of the meglitinides and then decrease their glucose-lowering effects. These include carbamazepine, which is used for seizures, rifampin, which is an antibiotic, and then the barbiturates. So you've got a drug that has TID dosing. You have to take it with meals. and numerous drug interactions. So this is just not something that most people are going to want to use. Skipping down to page 295, we'll talk about the alpha-glucosidase inhibitors. Now these are drugs that are also not widely used, and you'll see why when we talk about some of the side effects. The drugs we're talking about include acarbose and miglitol. The mechanism of action of these drugs, they have no effect on insulin secretion. They have no effect on insulin sensitivity. They cannot cause hypoglycemia, which is a good thing. The way they work is they inhibit this enzyme called alpha-glucosidase, which is found in the intestinal brush border. And by inhibiting that enzyme, you inhibit hydrolysis of saccharides to glucose and other sugars. So if you can't break down the saccharides, you can't absorb the saccharides, your blood sugar is not going to rise. In terms of pharmacokinetics, acarbose is minimally absorbed. It does most of its action in the gut. It's metabolized by intestinal flora. Miglitol is absorbed, but it has no systemic effects, and it's renally excreted. These drugs are used orally. Obviously, they're working in the gut, so you have to take them orally. Studies suggest they could be used in type 1 diabetes along with insulin. They wouldn't replace insulin, but they could be used with insulin. You have to take them with meals because they're only acting while you're eating. So you have to take it 3 times a day. They have very minor glucose-lowering effects. They're not very potent drugs. And they have a lot of unpleasant GI side effects. So the GI side effects include flatulence, diarrhea, and abdominal cramping. Basically, you're having more sugar remaining in your intestines, and that's causing an osmotic gradient that sucks more fluid in there, so you're going to have diarrhea, you're going to have loose stools, you're going to have a lot of flatulence, a lot of GI discomfort. Really, really not a very popular constellation of side effects, so most people don't want to take these drugs, and they don't work very well. So you can understand why they're not widely used. So let's talk for just a moment about some medications for hypoglycemia. Now, diabetes doesn't normally cause hypoglycemia. Sometimes patients will say, oh, I'm weak, I'm shaky, and then I eat something and I feel better, but it's often not proven that this is due to hypoglycemia. If you have proven hypoglycemia, it's usually from medication, either insulin or one of the sulfonylureas or one of the other drugs that can lead to some hypoglycemia. Now, if you do have hypoglycemia, there are 2 treatment options, glucagon and diazoxide. So glucagon is sometimes used for hypoglycemia, usually for emergency treatment. If they can't take an oral feeding or for some reason you can't get IV access and give them IV glucose, glucagon comes as an injection kit, and you can give an injection of glucagon. Glucagon is also used for bradycardia, and we'll talk about that in a moment. So the mechanism of action of glucagon, it's a peptide hormone that's produced in the pancreatic alpha cells, not the beta cells, but the alpha cells. And it acts to liberate glycogen stores and therefore raise glucose. It also has some potent inotropic and chronotropic effects on the heart, but it doesn't really act on the beta receptors. It acts in a different mechanism. It has an effect similar to a beta agonist, but it works at a different site. Rarely, glucagon can cause some nausea and vomiting, but for the most part, there's a very low risk of any adverse effects from it. The second drug to talk about is diazoxide, which has a very different mechanism of action. Diazoxide opens potassium channels. It's a thiazide, but it's not a diuretic. It opens potassium channels, and that leads to hyperpolarization of the cells, and therefore it inhibits insulin release from the beta cells. So diazoxide can be used for a couple of different things. It can be used for the emergency treatment of severe hypoglycemia. It can be used for patients with insulinoma, which is an insulin-secreting tumor. So these patients will have high levels of insulin and get low blood sugar, so you treat them with diazoxide to suppress insulin secretion. Diazoxide can also be used for hypertensive emergencies. When it opens those potassium channels, it causes hyperpolarization of the smooth muscle cells in the vasculature, so it causes vasodilation and relaxation of that smooth muscle. So the adverse effects of diazoxide, it can cause sodium retention, and it sometimes can cause some GI upset. So in summary, you need to know about the commonly used drugs, the ones you have to know, the sulfonylureas, which include glipizide, glyburide, and glimepiride. You need to know about metformin and the thiazolidine diones, which is pioglitazone and rosiglitazone. And you need to know about insulin also. It's very important in the treatment of diabetes. We covered that in a separate lecture. You should also know something about the newer drugs, the DPP-4 inhibitors and the incretin mimetics. They're not widely used yet, but they may be, and because they're new, very testable material.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide. Alright, we're back for our quick review number 2. Let's get started. Which medication should you avoid in patients with gastroparesis? That's going to be pramlintide. Next, which medications can cause hypoglycemia? Well, from the first section, we have to remember our sulfonylureas. They will often cause hypoglycemia. And then the DPP-4 inhibitors, sitagliptin and saxagliptin. And when they're combined with the sulfonylureas, you'll have even more hypoglycemia, so remember those. And then the meglitinides, the repaglinide and nateglinide, can both cause hypoglycemia. Next, why are the meglitinides not used as often as the sulfonylureas? They basically do the same thing. Well, mostly because of ease. So frequent dosing is problematic. You have to give these things 30 minutes before eating, so you're giving it 3, sometimes 4 times a day. And then there's a lot of GI side effects. So you're going to have some abdominal cramping, some diarrhea, and some nausea. Place the following diabetes drugs into their appropriate drug classifications. All right, so we have a long list of drugs here. Let's put them where they need to be. Synthetic amylin analog, that's going to be your pramlintide. The meglitinides are repaglinide and nateglinide. Alpha-glucosidase inhibitors is acarbose and meglitol. Incretin mimetics is exenatide and liraglutide. And the DPP-4 inhibitors are sitagliptin and saxagliptin. Those can be a little complicated, trying to figure out where they go. Use that chart there to help study later. Next, which medications have the positive side effect of weight loss? This is going to be the exenatide and liraglutide. And these are injectables, and a lot of patients will be real hesitant to do an injectable, especially if they're not already on insulin. But you can tell them, well, this has usually a several pounds, sometimes 5-pound weight loss when you take these medications. So it can be a bonus. Which medications prevent the breakdown and absorption of glucose? And this will be your alpha-glucosidase inhibitor. So this is acarbose and meglitol. Which medications can have the rare adverse effect of pancreatitis? Well, these are your incretin mimetics, and that's exenatide and liraglutide. And that's going to complete our quick review number 2.
Is your patient confused and lethargic, sweaty, dizzy with blurred vision, nervous and shaky? Another clear case of hypoglycemia? We have news for you. From deep in the jungles of Miami, our renowned scientists have discovered a miracle elixir that not only masks symptoms, but immediately cures low blood sugar. Though this elixir appears seemingly simple, its complex composition of flavonoids may be one of the healthiest natural abstracts on the face of the earth. Once extracted from this natural fruit, this is concentrated, frozen, and then reconstituted for an easy, convenient use almost anywhere. So, no more standing around frustrated and helpless. Orange juice, the miracle nectar.
Now is a good time to pause the video and complete the in-session quiz. Then restart the video and we'll go through the quiz together. All right, let's finish this up with the in-session quiz for your other diabetic medication lecture. Let's get started. Place the following diabetes drugs into the correct category. So we have a long list of drugs here. So our insulin secretagogues, that's tolbutamide, glipizide, glimepiride, glyburide, repaglinide, and nateglinide. Amylin analogs, that's our pramlintide. Insulin sensitizers, metformin, pioglitazone, rosiglitazone. Alpha-glucosidase inhibitors, that's acarbose and meglitol. Our DPP-4 inhibitors, saxagliptin and sitagliptin. Incretin mimetics, exenatide and liraglutide. Next, which of the above medications are classified as TZDs? That's our pioglitazone and rosiglitazone. Which of the following drugs above are given via subcutaneous injection? That's exenatide, liraglutide, and pramlintide. What are the most important adverse effects of the following medications? So sulfonylureas, we have weight gain, hyperinsulinemia, and hypoglycemia. And hypoglycemia is obviously the biggest one there. Metformin, big one for that one are GI disturbances, so nausea and diarrhea. Occasionally you can get lactic acidosis and impaired B12 absorption. TZDs, you can get weight gain and fluid retention and edema. And this is especially important in your CHF patients. You can switch them over to an exacerbation with that retained fluid. Increased risk of MI, and that's only with the rosiglitazone, not with the pioglitazone. Next, metformin is commonly used as a first-line diabetic medication. What are the contraindications to using metformin? Well, you want to be careful in patients with renal disease. And remember, your cutoff is a creatinine of about 1.5. But you also need to be careful in hepatic disease, acute MI, severe infections, diabetic ketoacidosis. You'll find when you start admitting patients that as soon as you see metformin, you end up taking away that medication because most of the patients you're admitting are sick or have something going on, and that metformin usually isn't worth it when they're in that state. You still have to watch their sugars really carefully. Next, what is the mechanism of action of exenatide? So this is our incretin mimetic. So the incretin effect, so this is basically when you have IV glucose or oral glucose, the incretin effect is that you get more insulin secretion as a result of getting that glucose load. So the GI hormones play an important role in nutrient absorption. So the exenatide is a GLP-1 gastric hormone homologue. So this improves the glucose-dependent insulin secretion, like we just said. But you can also get some slowed gastric emptying and some decreased appetite. And then you also get decreases in the postprandial glucagon secretion. And then finally, it can promote beta cell proliferation. Which diabetic agents work by delaying the intestinal breakdown and absorption of dietary carbohydrates? So this is our alpha-glucosidase inhibitors. So this is acarbose and meglitol. Which TZD is associated with an increased risk of MI? And this is rosiglitazone, not pioglitazone. Which diabetic agents require routine monitoring of liver enzymes AST and ALT? That's going to be your TZDs, the pioglitazone, the rosiglitazone. Which diabetic medications are potentially helpful in treating patients with polycystic ovarian syndrome? PCOS, so metformin and TZDs. And you can actually improve fertility just by taking these one of these two medications. What medication is sometimes used to reverse hypoglycemia can also be used to raise heart rate in patients with bradycardia, and that is glucagon. And that's going to conclude our in-session quiz for other diabetic meds. I hope you learned something, and good luck studying.